Good morning, ladies and gentlemen. Uh, Hope you're all doing fine. Our main purpose is to finish your theory classes as far as possible by the end of July or so that by the time you come back, you can concentrate mainly on your clinical surgical studies. This is something that we are planning. How far it's going to be implemented, I'm not sure. The topic for today's discussion is testicular tumors. It's only 1% of malignant tumors. I think I've hardly seen 20 to 25 cases of testicular tumors in my lifetime. So I don't know how much cases you will be able to see. So the incidence is very low. It affects the young adults between 20 to 40 years. That's the age where the testosterone fluctuations are maximum. And 90 to 95% of the testicular tumors arise from germ cells. And 99% of the testicular tumors are malignant. It causes psychological and fertility problems in the young. So it's a rare tumor. 99% of the testicular tumors are malignant and they occur in the age group 20 to 40. Now, today, previously when you developed a survival of the testicular tumor, the survival rate was very poor. But today there's an increase in the survival rate or improved survival rate in the last 15 to 20 years because of the better understanding of the natural history and pathogenesis of the disease, the reliable tumor markers, and the use of cisplatinum-based chemotherapy. Now, when you have a testis, you study its cross-section. It comprises of the stroma and seminiferous tubules. In the stroma, you have interstitial cells or the Leydig cells which secrete androgen. And tumors arising from here are masculinizing tumors. In seminiferous tubules, you have supporting or Sertoli cells which secrete estrogens. And there you get feminizing tumors and spermatogonia. Now, incidence is approximately 1.2 per lakh from the Bombay statistics and 3.7 per lakh from the USA statistics. Age 3 peaks, 20 to 40 maximum, 0 to 10 years and after 60 years. Bilateral testicular tumors are seen in 2 to 3% cases. So you can just imagine the incidence is very low with 3 peaks, young age group, very young age group, and above 60, and bilateral tumors in approximately 2 to 3% of the tumors. How do you classify testicular tumors? It could be a primary neoplasm of the testis, secondary neoplasm, or paratesticular tumors. Primary neoplasms may be a germ cell tumor or be a non-germ cell tumor. Now, what are the germ cell tumors? 1. Seminomas. 90 to 95% of the tumors are germ cell neoplasms, of which 40% are seminomas. Seminomas are further subclassified into classical type, anaplastic type, spermatocytic type of seminoma. 2 is embryonal cell carcinoma, 20 to 25%. 3 is teratoma, 25 to 35%, which may be immature or mature. And 4 is choriocarcinoma, 1%, and rarely you have yolk sac tumors. So germinal neoplasms are seminomas, embryonal cell carcinomas, teratomas, choriocarcinomas, and yolk cell tumors, the incidence of which has been described. Non-germinal cell neoplasm contributes to 5 to 10%. 1. Specialized gonadal tumors, Leydig cell tumors. As I already said, Leydig cell produced androgens, and so they are masculinizing tumors. And the other is usually the what you call Sertoli cell, which produces estrogen, and those produce what you call feminizing tumors. 2 is gonadoblastoma. 3 is miscellaneous neoplasm like adenocarcinoma of the rete testis, mesenchymal neoplasms, carcinoids, and adrenal rest tumors. Secondary neoplasms of the testis: A is reticuloendothelial neoplasm, B is metastasis from the bladder, seminal vesicles, prostate, etc. And the third category is paratesticular neoplasm, which may be adenomatoid, cystoadenoma of the epididymis, mesenchymal neoplasms, mesotheliomas, and metastasis. Etiology of testicular tumors may occur in cryptorchidism, carcinoma in situ, trauma, and atrophy of the testis. The risk of carcinoma in an undescended testis is 14 to 48 times the normal expected incidence, particularly in the intra-abdominal undescended testis. The cause of malignancy are as follows in cryptorchidism and testicular tumors. One is abnormal germ cell morphology. Two is elevated temperature in abdomen and inguinal region as opposed to scrotum, endocrinal disturbances, and gonadal dysgenesis. Now, today, the recent advances, you should know about the molecular biology, because molecular and genetical research may help future patients with testicular tumors in early diagnosing and to identify susceptible individuals. So, the diagnosis and treatment of what you call testicular tumors has markedly been revolutionized by the tumor and molecular biology. Now, proto-oncogenes in germ cell tumors are seminoma and embryonal cell carcinoma, NMYC expression, seminoma, C-Kairos expression, immature teratoma, C-ERB1 expression. Testicular germ cell tumors show consistent expression of both parental alleles of H19 and IGF2 genes. You don't have to go into the details of all this, but molecular biology helps to identify early cases of testicular tumors and familial susceptibility to testicular tumors. Now, how do you stage a testicular tumor? Stage A or 1 means confined to the testis. Stage 2 means spread to the regional lymph nodes. 2A is nodes less than 2 centimeters in size or less than 6 positive nodes. 2B is 2 to 5 centimeters in size or more than 6 positive nodes. And 2C is large, bulky abdominal mass more than 5 to 10 centimeters. So 2 centimeters, 2 to 5 centimeters, less than 6, more than 6 positive nodes, and 2C means bulky nodes more than 5 to 10 centimeter. And stage C is spread beyond retroperitoneal nodes or above diaphragm or the visceral nodes. Now, requirements for staging are: to properly stage testicular tumor, following are the prerequisites. You have to have a good pathology of the tumor specimen. History is important. Clinical examination findings are important. Radiological procedures like ultrasound, CT, MRI, bone scan findings are to be noted. And tumor markers, particularly beta SCG, AFP, PLAP, etc., have to be noted. So when you send your requisition after an orchidectomy to the pathologist, all these details have to be incorporated into it. TNM staging: T0 is no evidence of tumor. IS is pre-invasive. 1 is confined to testis. 2 invades beyond tunica albuginea or into the epididymis. T3 is invades the spermatic cord, and T4 is invades the scrotum. N1 single less than 2 centimeter node. N2 is multiple nodes less than 5 centimeter or single more than 2 to 5, up to 5 centimeters. N3 is any node more than 5 centimeters. And epididymis or scrotal skin, lymphatic drainage is to the inguinal lymph node. A question usually asked in the examination is, where does the testis drain into? The testis drains into the abdomen. The line of development has to be thought about. Always the lymphatic drainage follows the line of development. So the testis drains into the retroperitoneal nodes, whereas the scrotum and the epididymis drains into the inguinal lymph nodes. Pathogenesis and normal natural history. Course of spread of germ cell tumors are predictable once histology of tumor is confined. Lymphatic spread has a set pattern depending on the site of tumor. Seminoma may have non-seminomatous metastasis. High-grade tumors usually spread by vascular invasion and lymphatics. What are the investigations that you would like to do? First is usually an ultrasound, which shows enlarged testis, hypoechoic areas in the testis, and it may show also a secondary hydrocele. Chest X-ray to find out whether there's any metastasis. CT scan to stage the tumor. Tumor markers like AFP, beta-HCG, LDH, and PLAP. What are the clinical features of a testicular tumor? Painless swelling of one of the gonads, dull acheness or heaviness in the lower abdomen, 10% present with acute scrotal pain, and 10% present with metastasis, which may be nodal or distal metastasis, neck masses, cough, anorexia, vomiting, backache, lower limb swelling, etc. Lower limb swelling is mainly due to the lymph nodes pressing upon the main vessels. 5% present with gynecomastia and rarely with infertility. Dictum for any solid scrotal swelling: all patients with a solid, firm intratesticular mass that cannot be transilluminated should be regarded as malignant unless and otherwise proved. Tumor markers are mainly of two main classes. Oncofetal substances are AFP and beta-HCG. Cellular enzymes are LDH and PLAP. AFP arises from the trophoblastic cells and beta-HCG from the syncytial trophoblastic cells. AFP normal value is below 16 nanograms per ml. Half-life of AFP is 5 to 7 days. Raised AFP is usually seen in pure embryonal cell carcinoma, teratocarcinoma, yolk cell tumor, and combined tumors. Remember, AFP is not raised in pure choriocarcinoma or pure seminoma. Beta-HCG has alpha and beta polypeptide chain. Normal value is less than 1 nanogram per ml. Half-life is 24 to 36 hours. Raised beta-HCG 100% in choriocarcinoma, 60% embryonal cell carcinoma, 55% in teratocarcinoma, 25% in yolk cell tumors, and 7% in seminomas. Role of tumor markers helps in diagnosis. 80 to 85% of testicular tumors have positive markers. Most non-seminomas have raised markers. Only to 10 to 15% non-seminomas have normal marker levels. After orchidectomy, if markers are elevated, it means that there is residual disease. So it's not only in the diagnosis, but also follow-up, the tumor markers play an important role. Elevation of markers after lymphadenectomy means a stage 3 disease. That means it is spread beyond the diaphragm, supradiaphragmatically. Degree of marker elevation appears to be directly proportional to the tumor burden. Markers indicate histology of tumor. If AFP is elevated in seminoma, it means tumor has non-seminomatous elements. Negative tumor markers becoming positive on follow-up usually indicates recurrence of tumors. Markers becoming positive earlier than X-ray studies indicate recurrence. Principles of treatment. When you're treating a testicular tumor, treatment should be aimed at one stage above the clinical stage. For example, if you have a testicular tumor confined to the testis with no spread into the for example, nodes, you do an orchidectomy and radiate it. For example, in seminomas, radiosensitive, treat with radiotherapy. After an orchidectomy, give radiation to the retroperitoneal nodes. Non-seminomas are radioresistant and best treated by surgery. Advanced diseases respond well to chemotherapy. So, in diagnosing testicular tumors, the patients usually present with a testicular mass. The sensations are lost, firm in consistency. You do an ultrasound, it shows an hypoechoic area. Do the what you call tumor markers, AFP, then beta-HCG, PLAP, etc., LDH, etc. Now, would you do an FNAC in a case of a testicular tumor? The answer is no. No FNAC or testicular biopsy in a case of testicular tumor. The entire diagnosis depends upon your clinical findings, ultrasound, CT findings, and the tumor markers. And this is discussed in a tumor board, and there is no role for biopsy in testicular tumors. Principal of the treatment is radical inguinal orchidectomy is the standard first line of treatment. Lymphatic spread initially goes to the retroperitoneal nodes. Hematogenous spread is usually rare. Bulky retroperitoneal nodes or metastatic tumors, it has to be downstaged with chemotherapy. Stage 1, 2A, radical inguinal orchidectomy, followed by radiotherapy to ipsilateral retroperitoneum, ipsilateral iliac group of lymph nodes, 2,500 to 3,500 rats. Bulky, that is more than 6 centimeters, multiple huge lymph nodes, you do a radical inguinal orchidectomy and follow it up with chemotherapy. Treatment of nonseminomas, stage 1 and 2A, do a radical orchidectomy and you do remove all the retroperitoneal lymph nodes. The RPLND or retroperitoneal lymph node dissection means right from the renal hilum to the what they call iliac bifurcation, all the lymph nodes are removed. 2B means tumors more than up to 5 centimeters or multiple more than 6 lymph nodes. You do a retroperitoneal lymph node dissection and chemotherapy. And stage 3 and 2C diseases, initial chemotherapy followed by surgery for residual disease. For in all cases, orchidectomy is done. If it's a nonseminematous tumor, 1A and 1 and 2A, you do what you call retroperitoneal lymph node dissection. With 2C and 3, you give chemotherapy, and then if there is some node left, you can do a retroperitoneal lymph node dissection. Chemotherapy is usually bleomycin, etoposide, and cisplatinum. Toxicity of bleomycin is pulmonary fibrosis, etoposide, myelosuppression, cisplatinum, renal toxicity is usually seen. This is left hydronephrosis. You can see in a kidney due to what you call, the main thing is mainly due to what you call due to a large para-aortic nodal mass. Lymph nodes usually from the renal hilum up to the what they call iliac bifurcation, you have to remove all these fluid. That will include paracaval, infracaval, para-aortic, retroaortic, all those lymph nodes have to be removed. Iliac group of lymph nodes, etc. will have to be removed. Therapy of patients with seminoma, stage 1, 2A and 2A, abdominal radiotherapy after what you call the orchidectomy, stage 2B, 2C and 3, orchidectomy followed by BEP, bleomycin, etoposide, cisplatinum, 4 cycles. Follow-up in cases of what you call stage 1, stage 2 stable or regress, we follow up, relapse or growth, you'll have to do a retroperitoneal lymph node dissection. Think of radiotherapy or chemotherapy. Therapy of nonseminematous germinal tumor, stage 1 and 2, you do a orchidectomy with retroperitoneal lymph node dissection, then observe the patient. 2B2, you have to give what you call chemotherapy of bleomycin, etoposide and cisplatinum. Then therapy for nonseminomatous germ cell tumor, radical inguinal orchidectomy. Advanced cases, you give chemotherapy of BEP, 4 cycles. Observe the response. If it's a complete response, observe the patient. Partial response, go in and do a retroperitoneal lymph node dissection. Then if it is the progressing, you do autologous bone marrow transplant is something that is thought about. Prognosis of seminoma, stage 1, 99%, non-seminoma, 95 to 99%, stage 2, 70 to 92%, non-seminoma, 90%, stage 3, 80 to 85, non-seminomatous, 70 to 80%. In conclusion, there's an improved overall survival of testicular tumor due to better understanding of the disease, tumor markers, and cisplatinum-based chemotherapy. Current emphasis is on diminishing overall morbidity of various treatment modalities. Kind of.